Hey friends, welcome back to the Journal Feed. My name is Nick Zelt, and this is the only place to get spoon-fed the latest and greatest of emergency medicine. This is the audio version of the past week's articles, which this week were brought to you by our authors, Chris Thome, Catherine Solkowski, Rebecca DeFabio, Millie Cosse, Kitan Patel, and Clay Smith. All right, the first article titled Quality Matters: The Impact of a Physician in Triage Deployment on Advanced Imaging Utilization, out of the American Journal of Emergency Medicine. So everybody wants things to be faster. Everybody wants the throughput to be faster in your emergency department, of course. And we also want those metrics to be better. Less patients who leave without being seen, and faster time to actually seeing the doctor for the first time. These are metrics which are quite important in a lot of places, but they're not necessarily that important for the patients per se. We want better outcomes, and they're not the only things that we measure either. One way to get some of these better sort of throughput measurements is to put a physician directly in triage, and they can help direct the flow of patients and start workups as appropriate. Here in this center, this study, they were looking at an emergency department which implemented this. They put a physician in triage. This is a pretty decent-sized emergency department. It's a tertiary academic center, which sees about 70,000 patients a year. Pretty good. And now this study is a pre-post quality assessment of putting that physician in triage to look at the imaging rates that resulted from this. So they had a physician in the triage, and they could either sort of angle the patient over into a rapid assessment, sort of more vertical patient orientation, depending on their acuity, or they would put them over into the monitored care setting of a different physician. If they took them into the vertical area, then they actually became their own patients, and they were able to follow them through unless they got too complicated. What these authors were primarily focusing on was CT utilization pre and post implementation of this physician in triage. So they looked at the 18 months before and the 18 months after implementing this, where the emergency department saw about 77,000 patients before and 89,000 afterwards. And what they saw for CT utilization is that it went up, and significantly. From 0.36 studies per emergency department visit to 0.49 studies per visit. So that's about half of the patients overall getting a CT scan, and about a 13-14% increase in CT scanning as an absolute measurement, which is quite a bit. When they dig down a little bit and they just look at CTs of the abdomen, of course, this is quite significantly increasing, an adjusted odds ratio of 1.38, which is huge. The only imaging modality that actually decreased, unfortunately, was POCUS, which is the only thing that we don't want to decrease and we'd like to have more of, because POCUS is nice. It's great for our patients. It's great for us. It's great for everybody. There were decreases, significant decreases in the rates of left without being seen and door-to-doctor times, but these are just numbers that we're kind of forced to look at by people that are more numbers people who just want to think about throughput and not what's the best care for our patients. Mind you, all of this is single center retrospective data, and this was only for day shift hours when they actually had a physician in triage. So there's definitely some limitations, and this won't apply everywhere, but I think it makes sense. They even make reference to the fact that now, patients have to make it past 2 emergency physicians without getting a CT scan, which clearly means that more people are going to get scanned. Now, I recall in a nearby hospital to me, it was the pediatric center, though. They were bursting at the seams somewhere around COVID time, just way too many people. And so it was actually proposed that they have a doctor walk around the waiting room and assess patients really quickly to see if, hey, you don't need to wait here, you're probably fine. That was a crazy story. There's no way I would volunteer for that job, because you're doing, I'm going to say shoddy assessments really quickly done. There's a reason it's called just triage. You get a quick idea of where these patients should go, but patients still need a proper full assessment. So if you're only doing these really quick evaluations, then yeah, of course, you're going to be a little bit more liberal with some of your resources, including scanning, to make up for the fact that you didn't ask so many questions. So, of course, it's a very interesting idea to put a physician in triage, but maybe we're suffering in terms of our CT scan use. In a spoonful, a physician in triage in this study increased CT imaging while decreasing POCUS, and it certainly didn't seem to improve patient care. Okay, then let's skip over to the fourth article. Titled Fresh Frozen Plasma First Approach is independently associated with improved survival in severely injured patients undergoing massive transfusion, out of the Journal of Trauma and Acute Care Surgery. Now, of course, we go for damage control resuscitation and we like to get in those ratios at 1 to 1 to 1, assuming you're not using whole blood, you're using component therapy. Though this is actually poorly taken up in many places, and it's been very difficult to get everybody up to speed on really getting in that 1 to 1 to 1 reliably. Now, despite its sort of simplicity, there are some, complicating factors to it. They're not all actually packaged 1 to 1 to 1. You're not actually giving, one bag of each one like this. So it can be kind of complicated, of course. And most of these protocols, well, they prioritize in giving PRBCs first because, PRBCs are the thing that's lacking that the patient needs to survive. You need oxygen carrying capacity to get to all your cells for you to live. However, PRBCs are not going to stop your patient from bleeding. And we know that in severe trauma that you have definite coagulopathies that are, can be quite significant and they keep you bleeding. And that's what's going to cause the problem. So you're trying to get a balance here between giving back what the patients need and, your damage control, actually addressing the problem. So in order to address this problem, you need to replenish those, coagulation factors, which comes in the form of FFPs. Your platelets are, can be helpful too, but FFPs are what's going to give back a lot of the proteins that you're lacking. So if you gave FFP first and prioritize that as the first thing that you transfuse, would that be helpful instead of PRBCs? Not instead of completely, but prioritizing to give them first. So this was a database analysis where they tried to get down to the root of that problem. And they seemed to base this on ICD codes and the order that they were inputted. So they saw that FFP was given first. If they were given at the same time, then they didn't count those patients. I'm not sure how reliable this actually is or how this is input into the system as something that is a reliable trigger for how these products were given. But all the same, they analyzed when it was said that FFP was given first and looked at patient outcomes as a result. So you actually see a 1% absolute difference in the adjusted analysis for an improvement of survival at 6 hours and even survival to discharge. This ends up with an odds ratio of 1.1 for survival to 6 hours and 1.06 for survival to discharge. So there does seem to be a statistically significant improvement in these patients who seem to get FFP first, which is interesting, but we're definitely going to need to know a lot more about this. And perhaps this will be something that could be trialed, in the future at some point in other studies to see if this is really the right way for us to be going. Honestly, for massive transfusion protocols, a lot of these sort of level 1 infusers give them pretty much all the same time anyways. And it's also complicated by the fact that this is fresh, frozen plasma. So it actually has to be thawed, and it's very difficult to get to you as your first component if it's thawed, unless you're working at a center that is very high volumes and can just have it pre-thawed on hand because they know they're going to use it. That's not going to be the case in terms of availability in most places. Perhaps this is the mechanism by which whole blood is more effective because you're doing both at the same time. You're giving back those proteins that are missing and you're also giving PRBCs. Maybe that's why whole blood is, everybody's so positive about it. And there does seem to be some trials that do support it as more effective because maybe you're doing both things at once, which is actually, getting to the root cause of the problem. So in a spoonful, this is interesting but retrospective data which relied on coding, which implies that perhaps prioritizing FFP first during a massive transfusion protocol would lead to better patient outcomes. Okay, that's all the articles from this week. Let's do a quick wrap up of everything we talked about. From the first article, we saw that a physician in triage, well, it can be great for throughput times, but it's not so great for how many CT scans we get. Then from the fourth article, FFP-first strategy for massive transfusion protocols might be better by a single percentage point in this retrospective study. This will require further looking into. If you were hearing this right now, then you were not a part of the members feed, and so you missed 3 articles from this past week. What were those articles that you missed? Well, one was about T and L spine injuries in children. How reliable is the exam and x-rays? Another was about a clinical decision support tool for adrenal insufficiency and if giving that reminder really helped patient care. And then finally, a review of C-spine imaging practices in both adults and children. Links to all the original articles can be found at journalfeed.org or just follow the links in your show notes. Our goal here is for you to keep up the easy way through spoon feeding. Thank you.